two standard pillars of managing the PTC. First of all, whether should we call it micro, but that is again, I mean, that debate is a different thing. But then two standard pillars of management for the micropapillary thyroid carcinoma is well managed by my two previous speakers. I am given the thing which is yet not established. But I'll try to justify the role of ablation for the micropapillary thyroid cancer management in the few minutes given to me. So I'll start my slide with this disclaimer, which is very much pertinent, and I'll try to put certain slides and evidence that will prove my point that why there is lot of interest. Perhaps the highest interest in the thyroid management right now is the ablation of thyroid nodule. So micropapillary carcinoma, we all know, generally is defined particularly low risk. I'm going to talk about the low risk MPTC. Those which are less than 1 centimeter, you have those who doesn't have at the presentation any nodes present, no distant mats present, no extrathyroidal extension, and without aggressive histology. I'm sorry, it's not working. So it may be multifocal bilobar, but then again it should be based on the low risk. And out of the incidentaloma, which we now know that put your sonography probe on my neck and perhaps I'll have something in my thyroid. So out of that, at least 3.5% of them are malignant, and we know that luckily 85% of them are less than 15 mm in diameter. So we know that surgery is gold standard, and we are learned, and in our medical school also it is very well documented that go for surgery, anything cancer in the thyroid, you must go for the surgery. And we know that this is specific mortality, loco-regional recurrence rate and distant recurrent rate is very low thanks to treatment, but there is something else also, and that is partly complication rate. In spite of the high burden, high volumes surgical units also, the complication rate reported is, nearly 4%, though it may be transient, some of it may be permanent. Something, why? Because this complication rate was there, number of incidentalomas were rising, and we have a too large study reported something about active surveillance, and that's how the ball started rolling. So, in the long follow-up of active surveillance, we could see that 7% showed the increase in size, and 3.8%, roughly 4% developed nodal mats at 10 years of follow-up. However, no patients showed significant recurrence or died of PTC while under follow-up, and those patients who underwent delayed surgery. However, concern was psychological anxiety of the patient, because the moment you say that, hey, you have a cancer in the neck, the anxiety is a big problem, and many of such patients underwent a delayed surgery just because of anxiety. And more relevant point was this, that less than 40 years of patients had a little more progression rate than the average. That is, around 9% of such patients had progression in the active surveillance group. So it is quite likely that these excellent outcomes are more related to the indolent nature of the disease and rather than to the effectiveness of the treatment, perhaps. And then came the concept of thyroid ablation. Can we bridge between two pillars? So while this was going on, the availability of ultrasound-guided thyroid ablation techniques started available in the market, and it was getting used for different other organs of the body. There was increasing prevalence of thyroid nodules, either previously undiagnosed or asymptomatic, and sometimes patients' demand for non-surgical therapy options, and of course few patients, but those who are truly surgically high-risk patients, how to deal with. So there were certain large multi-center retrospective studies started putting their data, and here the good result from a multi-center retrospective Korean study reported that there was nearly 70% of the complete disappearance of the thyroid nodule with the ablation. And disease progression was very less, with 7 of large 847, that is 850 patients had new tumors, and all were reablated. And delayed surgery was done only in 2 patients while the follow-up. Even in the bilateral MPTC, with the follow-up of nearly 4 years, the complete disappearance rate was quite promising, and complication rate was almost, comparable or even less than the surgical arm. And all recurrent lesions underwent additional RFA. The benefit of ablation was that we can use it again and again, and there was no life-threatening or delayed complication. So microwave ablation. So this, another previous 2 studies has a combination of RFA and microwave both, and pure microwave ablation for MPTC, again with the 5 year of follow-up, showed the same good promising results. So just to mention about the thyroid ablative tools, as we all know, for the cystic nodules, ethanol works better. For the smaller nodules like around 10 mm, 12 mm, laser ablation is good, and radiofrequency and microwave ablations are good for the kind of solid tumors. And there is coming up is a high frequency ultrasound, high focused frequency ultrasound. So how can we compare, and what are the merits and demerits? So problem with laser ablation, it's good tool, but difficult for the larger size tumor, or at least more than 15 mm. Sometimes the results is not as good. While percutaneous injection of ethanol is gold standard for the cystic tumor, but for the spongiform or the solid tumors, not that much helpful. While RF is good, it uses electric current. Microwave is better, it uses electromagnetic waves. Problem with RF is heat sink effect. So that's why sometimes those tumors which are close to major vessels, or those which are vascular tumors, effect of RF is less, which is not with microwave. The only problem with microwave is antenna size, and sometimes the hematoma rate is a bit higher. So what is the principle? First is to reduce the nodule volume. Here we are not going to go with the size of tumor. We are going to go with the volume of tumor by irreversible coagulation necrosis. Hydrodissection prior to ablation is useful for protecting vital structures and defining areas. Replacement of tumor by hypoechoic area indicates complete ablation. So this is the procedure generally done in the OR. Patient in supine position with neck extended, local anesthesia with some sedation preferred, and site of hypoechoic nodule is shown in the picture is defined with good high frequency ultrasonography probe. And this is, mind you, is a multidisciplinary approach. Not only surgeon or radiologist alone can do. The technique generally used is either moving shot or fixed applicator technique. Procedure is small, short. Observation is done for 2 to 3 hours. Expected post-op things are like mild pain, maybe deep burning sensation. It's common, but it resolves on its own. We have to observe, particularly in the first 24 hours for the hematoma. So these are the pictures of the nodule before at 1 month, 6 months, and 12 months. We can see the considerable VRR. So now how to compare, we have 2 standard modality of treatment, why should we go for the third one? So if we compare with the thyroid lobectomy, so at the end of more than 4 years, there was no significant difference in the form of tumor control, LNM, or in the recurrence locally, or maybe persistence of the disease or relapse-free survival between 2 modalities. So where was the difference? RFA has a shorter procedure time as compared to surgery. It has lower estimated blood loss, shorter hospitalization, and lower cost, and of course, lower complication rate as reported in the literature by the scientists with a large number of patients. So now if we compare thyroid ablation with the active surveillance, again, we have seen, my previous speaker also mentioned that around 7 to 8% of these active surveillance patients are going to have an increase in the nodule size. Around 4%, especially young patients, are going to develop LNM. That is very striking, and then we have to go for wider radical surgery. Substantial number of patients in active surveillance undergo delayed surgery just for the sake of psychological trauma. And LNM rate for T1A is okay, but for T1B, there is a statistic difference between the two modality, that is 0.6% and 3% in the active surveillance group. So limited number of, important is this, that limited number of centers can offer reliable lifelong clinical and ultrasonography surveillance. So certain tumors are not ideal for the active surveillance, that is ischemic tumors. And of course, the certain tumors which are close to the dorsal capsules can be difficult to observe as an active surveillance modality. So my take home is like this. Application of TA, thyroid ablation to malignant thyroid nodule has largely been restricted to very small, usually 10 mm diameter nodule without any high-risk criteria. Patient with significant medical contraindication to surgeries can very well be offered, and particularly those patients who have anxiety or patients who refuse surgery and active surveillance both. Thyroid ablation works as a breeze. Cervical recurrence, that is neck recurrence in patients with high surgical risk or for those who refuse surgery. So even in recurrent certain well-indicated cases, it is important. So last slide, absence of dedicated guidelines, uncertainty about clinical long-term outcome, concerns of side effects and fear of overlooking malignancy are the reasons for reluctance of thyroid ablation use in malignant thyroid nodule. Future studies are expected to establish the impact of molecular profiling, and then it will further guide us which modality to be selected for which nodule. Thank you.